So now I'll ask the hepatology faculty to please join me up here on stage for questions. We had a few cases, but I think we'll go over the questions instead, because these questions were covered in some of the cases. So I think we'll get to go through everything. So joining us also Dr. Kara Walter. She is one of our hepatology faculty members who joined in Santa Monica. Dr. Walter joined after completing her training at University of Washington for gastroenterology and transplant hepatology, and she's a clinical instructor of medicine. So everyone is in the hot seat. Are you guys ready? So the first one is a hepatitis B question. There is a new movement to treat immune-tolerant patients with just based on age alone, patients who are over 30 years old based on the EASL guidelines. Any comments? What if the patient has family history of liver cancer? Dr. Han?
Yes, that is absolutely true. That immune-tolerant population has always been controversial. I mean, if you were to ask a group of liver specialists who would treat the immune tolerance versus not, the room would probably be split right down the middle. But so the proponents of not treating have always pointed to long-term studies and biopsy studies that have shown that immune-tolerant patients have no progression and are not any worse than normal patients. But it's now becoming more evident, and more studies are coming out showing that patients with elevated viral load are at increased risk of liver cancer. Patients with a family history of liver cancer are a different group. So among the immune-tolerant patients, there are probably what I call super at-risk patients, and it's now the guidelines are saying that perhaps we should consider treating the immune-tolerant patients with a family history of cancer, those older than 40 years of age, and that's purely a time thing. You know, a 40-year-old Asian has had 40 years of hepatitis B, and that's 40 years of high viral load, and the risk is there. So it's a work in progress, but those points are correct, yeah.
So this is kind of a follow-up question. This is for hepatitis B viral load, high viral load but normal ALT. Now with the non-invasive studies, would you recommend FibroScan or other non-invasive testing for treatment?
Yeah, that's a very good question and a very good point. Yeah, in the old days, biopsy was very invasive, but now we have great fibroscans, MR elastography. And yes, if you use a non-invasive method and you document objective fibrosis, and what a liver biopsy was looking for was anyone with F1, F2, F3 fibrosis. If you could show objectively that a immune-tolerant hepatitis B patient was developing fibrosis, that was a patient that you should consider treating. So now, with the non-invasive, if you do your fibroscan and their F2, F3, then that could be an indication to put them on treatment too.
Sounds good. So this question is for Dr. Kabany. In cirrhotic patients with hyponatremia and ascites, do you recommend tips? How low of a sodium is too low?
Okay, good questions. For tips, there is specific criteria to select. First of all, you have to be sure that they have a good ejection fraction of their heart. You have to be sure that they are 65 years or less. And of course, you have to look at the MELD score. In addition to that, you have to get good history and see if they have recurrent hepatic encephalopathy or not. I expect patients with low sodium will have higher MELD than 15 or 18, because hyponatremia per se is a bad prognostic factor for cirrhotics.
Thank you, Dr. Kabany. So this brings me, this was one of the cases that I actually had prepared for today. I had a patient who was, to kind of tie into this, she was a 59-year-old homeless patient with a hepatitis C and alcoholic liver cirrhosis. She was referred to established care and follow-up. Her main issue with refractory ascites and non-bleeding esophageal varices. She lives in a shelter. Her family lives in a different state. She's not very compliant with a 2-gram sodium diet. Her MELD always, for the sake of time, I'm not going to go through the entire thing, but her, long story short, her MELD score hovers between 10 and 14. These are her most recent labs here. No cancer. She had a big workup, and we're thinking about the possibility of doing TIPS in this patient. She's not super hyponatremic. Her sodium hovers between 130 to 136, depending on her diuretic regimen. But she may never be a transplant candidate due to her social support. So I kind of wonder what the panel's thoughts are in terms of placing a TIPS in such a patient.
What are the other underlying conditions? Heart is okay.
Yeah, she's otherwise pretty healthy. Heart is okay. She got an echocardiogram that was normal. No HCC, no blood clots in the liver circulation or anywhere else.
No recurrent hepatic encephalopathy.
No history of hepatic encephalopathy.
And kidney is okay.
Kidney's normal.
Well, in fact, if the patient is well selected, there is survival advantages of TIPS, provided they fulfilled everything, and she is less than 65. I would go for TIPS.
Yeah. Or what?
As Dr. Kabany said in his lecture very nicely, TIPS is a rather safe procedure. There are two major concerns with TIPS. Dr. Kabany mentioned there's a risk of encephalopathy of 40–50%. The biggest predictor, as he said, was pre-TIPS encephalopathy. So if this lady's homeless, I'm worried who's going to be monitoring this young lady.
Right.
Number two, the second big risk with TIPS is liver failure. Now, if you ask sometimes see liver failure with TIPS, it's probably 1 every 5–10 years, very infrequent. So I would prefer, if we're going to consider someone like a TIPS candidate, would prefer them to be first considered a liver transplant candidate, because I need out. If the liver goes to failure and I can't occlude the TIPS, what am I going to do? So that's my, I would first consider a transplant candidate, and then, and make sure there's a better housing situation.
I forgot that she is homeless.
Yeah.
Because whoever is going to be scheduled for TIPS, he should be on a liver transplant list, not only because of the chances of liver failure, but also for the chances of the failing of their heart, because long-standing TIPS can put more burden on the heart and cause heart failure as well. That's why it is a bridge for liver transplant, not a curative treatment.
Someone like this who may not be a transplant candidate, I mean, something we used to do many years ago was a Denver shunt, a Levine shunt. We have great surgeons do those shunts if need to. So that doesn't increase risk of encephalopathy. That's not associated with any liver failure. So someone like this I may consider for a Denver or Levine shunt.
I think one other thing you have to keep in mind is sarcopenia. So if your patient is sarcopenic and you're thinking about tipsing them, you have to be very, very careful because they decompensate pretty badly after the procedure.
Thank you. So this is for Dr. Choi. If patients only has a high ANA along with high AST, ALT, but otherwise negative anti-smooth muscle, negative IgG elevation, would you do a liver biopsy to rule out autoimmune hepatitis? I guess the only thing that's missing in this context is whether, actually it does say here with high AST, high ALT. So only positive ANA, high AST, ALT.
So I guess you have to also just assess their other risk factors, right? So if you told me positive ANA, high AST, ALT, the first question is how high is their AST and ALT? And common things being common, this is most likely fatty liver. So if you ask them what their metabolic risk factors are, if they have diabetes, high blood pressure, I wouldn't jump to biopsy right away. I'd say, look, we need to get really aggressive about weight loss, management of metabolic comorbidities. If they do all that and it's still high and it's a woman and she has other autoimmune diseases, then I would be more inclined to do a liver biopsy. None of these patients ever look the same. So, but you kind of have to really take in each individual person. But positive ANA is positive in normal, healthy people, right? So all that's ANA and SME positive is not necessarily autoimmune hepatitis.
Yeah, I would just add in conjunction, I think we're also seeing a lot of isolated smooth muscle antibody positivity in patients without concurrent IgG elevations or even ANA positivity. And many of those patients also have underlying metabolic risk factors and more likely have non-alcoholic fatty liver disease. So we just have to think about that as well. I think some studies suggest about 20 to 25% of patients with NAFLD will have positive antibodies.
And the third thing, like Gina said, it depends on how the liver tests are. There are 1,000. I mean, they're pretty worried. If there's 65, but you might also want to buy time. The other thing they call is elevated low titers of ANA, low titers of SMAs DILI. So, like Gina said, a good history. Are they taking shark's cartilage or some herb or green or green tea extract? So we got to get a good history. But remember, there are also drugs that cause very low titers of ANA, SMA, and elevated liver tests.
And it's very interesting because as we started practicing, as I started practicing in Santa Monica, one of the most common consults I used to get initially when I first started was positive anti-smooth muscle antibodies with nothing else, and very mild elevation in transaminases. What I often found was that patients are taking something over the counter, and sometimes it's as simple as turmeric pills. Now, is turmeric harmful? I don't know. This hasn't been reported, but was there some sort of contaminant that caused this, and they would stop the over-the-counter medicines or whatever herbal supplements they were taking, and the anti-smooth muscle antibodies would go down. So hepatitis, this hepatitis B question, for non-cirrhotic chronic hepatitis B patients, how to decide who needs HCC screening and how frequent to screen? Is every 6 months an appropriate interval?
The current guidelines still say that in the average risk hepatitis B patient, you should start screening for HCC in men over age 40 and women over age 50. If there's a family history of HCC, then you should start screening even earlier. My practice is to start screening patients as soon as they enter my practice. So I screen all my hepatitis B patients, and I mean the routine standard screening techniques are still an ultrasound plus a serum AFP. So the imaging is very important. AFP alone is not adequate and is discouraged by the AASLD. So you have to get an imaging study, and an ultrasound every 6 months is probably the minimum that you need to do.
Thank you, Dr. Hahn. So this question is about PBC. Is it true that ursodiol helps the lab numbers normalize but does not change the liver biopsy results?
So that's kind of tricky because PBC is a very patchy disease. So in terms of biopsy, there might be areas that you don't always catch. So biopsy isn't always 100%. If you do start PBC and you start ursodiol, we follow liver tests because these are chronic diseases that take decades to manifest into the ultimate dreaded endpoint, which is cirrhosis. So that's why we use alkaline phosphatase, bilirubin as surrogate markers to see how we're doing. So I usually biopsy in the beginning. I usually don't to make the diagnosis and to get fibrosis staging. I don't really biopsy subsequently, but usually there is a correlation with improved liver tests and improved outcomes.
Does just curious from the panel's point of view, does anyone else rebiopsy after normalization of labs or after using ursodiol?
I think the consensus is to avoid biopsy completely, and for sure not afterwards.
Yeah, that makes sense. Thank you. So, class of drugs to be absolutely avoided in hepatitis C in decompensated cirrhosis.
So I think Kabany did a really good job of going over some medication, but the two classes of drugs we want to avoid completely are non-steroidals. So people go, oh, her Tylenol is bad for you. Yeah, but but non-steroids are worse because they affect prostaglandins. So A, they affect your bleeding. Number two, there's a high risk of kidney failure. So nonsteroidal is a big no-no. Taking Tylenol at FDA-approved doses is fine. We don't want to take a whole bottle of it, right? But a couple of pills is fine. The second class of drugs you need to avoid are aminoglycosides. And we all learn from medical school training that it causes kidney failure. So two big buckets of medication are nonsteroidals and aminoglycosides. And Dr. Kabany mentioned other drugs as well. They should avoid too.
Yeah, this was, I mean, that was a great answer, this is something that we all really need to know, but I think they were asking about hepatitis C medicines to avoid in decompensated cirrhosis.
So usually hepatitis C medications?
Hepatitis C medicines,
in cirrhotics.
Yeah, so that's a good question. So a question about hepatitis C medications. So you have to avoid drugs that include protein inhibitors. And so there are some drug combinations that have a PI in it. Right now, the FDA has 2 drug combinations that are approved for people with decompensated liver disease with ribavirin for 12 weeks, or you can do an extended duration of 24 weeks. So if someone's got a MIL score of 35 and they're in the ICU, they're going to need a transplant. But if someone's got a MIL score of 20, 25, I would consider antiviral therapy, and the hopes that, first of all, that maybe improve their liver function over time. Number 2, if they get transplanted, the hepatitis C won't come back and reinfect the liver. Now, people have argued that might do harm, because what we're seeing is increased number of hepatitis C positive organs. So if someone's cured of hepatitis C, they may not be eligible for the hepatitis C positive graft. Now, so far in California, it hasn't been a big deal. So treating advanced liver disease, I would, but either you do extended therapy for 24 weeks for soft atmosphere, or 12 weeks plus ribavirin, and not be greedy with ribavirin. I would not go more than 600 milligrams a day. I would not do weight-based dosing.
Well, I also wanted to mention, I don't know if Sammy mentioned this, but if you're going to treat a hepatitis C patient, you do have to screen for hepatitis B surface antigen and core antibody, because there's been cases of reactivation of Hep B during hepatitis C treatment.
That's right.
Yeah.
Thank you.
The other medication that should be looked at before starting a hepatitis C patients is whether they are on PPI or not, because PPI can impede the efficacy of the direct antiviral agents with certain medications.
Yeah, those are the black box warnings that have been placed on the FDA label for the hepatitis C medicines that the panel has talked about. Do not use of amiodarone. It can cause severe bradycardia, and protease inhibitors in patients who are decompensated can cause worsening decompensation and death. And lastly, the decompensated patients should not be on protease inhibitor. I probably mentioned that, right? So for Dr. Han, what is BCP mutation of Dr. Tong's criteria, and how do you check for it? And then another question on the same card, what is your opinion on elevated ALT? Does it need to be 2 times the upper limit of normal? What is the upper limit of normal? Or would you treat anyone with high ALT?
So for the first, so the BCP mutant, which is the basal core promoter mutant, and also the PC mutant, which is the pre-core mutant. So those are the 2 genotypes that define an E antigen negative patient. So BCP mutants and PC mutants will by definition be E antigen negative. And you can determine if your patient is basal core promoter or PC mutant by getting an HBV genotype testing. That also gives you the genotype of hepatitis B, and also tells you whether they have resistance to any of the antiviral drugs. So my own practice is when I see a new hepatitis B patient, I always order genotype. You should also check for hepatitis delta virus in addition to viral load, E antigen, that type of thing. So Dr. Tong, in his big study, found that BCP and PC mutant patients are more aggressive. They develop liver cancer more commonly than non-E antigen negative patients, and so that's why he added the BCP and the PC mutants in his risk stratification score. Then as far as the ALT, There's controversy, the AASLD guidelines still say ALT 2 times upper limits of normal is considered abnormal. EASL, the European Society, and also Dr. Tong's Asian American algorithm have said above upper limits of normal is good enough, does not have to be 2 times upper limits of normal. And then the big question comes up, well, what is upper limits of normal? And our current recommendation really is to use the upper limits of normal in your lab, to make it simple. If you want to, the AASLD says to use 19 for women, 30 for men. That's incredible. I mean, when is the last time you saw someone with an ALT level of less than 20? In this day and age with fatty liver, it's just. But if you use the upper limits of normal in your lab, the range of normal in a lab is determined by a bell curve of the population that is seen by that lab. So we felt that for consistency's sake, across all different etiologies of liver disease and geographies, the easiest would just be to use the upper limits of normal in the lab that you use.
Thank you, Dr. Han. So one last question, I know because we were standing between lunch, are the risk of developing liver cancer equal for hepatitis B and C or higher for hepatitis B? And how about autoimmune hepatitis?
So there have been a number of studies comparing the relative risk of liver cancer among different diseases. And unfortunately, like Dr. Han said, untreated hepatitis B probably has the highest risk of liver cancer because hepatitis B itself is a carcinogen. And then untreated hepatitis C and hemochromatosis is probably close second and third. Autoimmune hepatitis, PBC are way down the list. In the middle, you have alcohol. And fatty liver. But hepatitis B, it's a hemicarcinogen. So the risk of liver cancer, particularly untreated, is probably the highest. Unfortunately, the guidelines don't differentiate between among the indications for the cause of cirrhosis, or everybody's treated the same with every 6 months ultrasounds with advanced liver disease. Or like Dr. Han said, if someone's got a high viral load, family history, they'll start earlier. Liver cancer screening. And the standard of care is abdominal imaging with AFP. The FDA just recently approved the GALAD score, GALAD, for screening for liver cancer as well. And what that does is it has some additional tumor markers. It looks at subsets of AFP called AFPO3. It looks at deoxycarboxyprothrombin, DCP, and that's a spinoff of prothrombin. So there's a new score for use for liver cancer screening called the GALAD score, just approved by the FDA this week.
Great. Thank you very much, panel. Thank you,
Beshoy.
everyone, for your attention.